Hi everyone. Thank you for joining our webinar today on suicidal behaviors in clinical high-risk populations with Dr. Shirley Yen. I'll be turning things over to her shortly, but first I'd like to review a few housekeeping items with you all. Please remember to mute your computer speakers if you're calling in via phone. The computer speakers can be muted through Adobe Connect by pressing on the green horn above the presenter's pod. This webinar is being recorded and will be available for viewing at a later time on the MHTTC website. The PowerPoint slides and any additional resources discussed today will be available later today as well. During the presentation, if you have any technical difficulties or questions about the topic, you can use the chat and questions box down on the bottom left. Those attending today's live event will be eligible to request a certificate. More information regarding CEUs will be in a post-webinar follow-up email. And to reach us after the webinar, you can email newengland@mhttcnetwork.org. Our MHTTC mission is to use evidence-based means to disseminate evidence-based practices across New England. Our area of focus is geared towards recovery through recovery-oriented practices and support services within the context of recovery-oriented systems of care. To ensure the responsiveness of our work, we will actively develop and maintain a network composed of different stakeholders from each of the 6 states to guide our activities. To learn more about us, you can visit our website as well. And with that, it is my pleasure to announce our speaker today, Dr. Shirley Yen.
Good afternoon, everyone. Okay. Are my slides up? Can anyone see my slides? Oh, there. 1 second while we get the slides up. Oh, okay. All right. Let me just get started. I actually can't see my slides, so I'm going to start, and hopefully they will come up, and then, oh, let's see. Wonderful, great. Okay, so today I'll be talking about suicidal behaviors in clinical high-risk populations, and what I'd like to do today is to briefly review the research on the increased risk of suicidal behavior in youth and young adults who experience psychosis symptoms, and also provide an overview on the basics of suicide risk assessment, as well as provide some examples of intervention strategies using clinical vignettes with a specific focus on safety planning intervention. So now, we know from several large-scale studies, including the SAIL study, that having psychosis symptoms significantly increases the risk for suicidal behavior. And by suicidal behavior, what this refers to is really a number of behaviors, including suicidal ideation, having plans of suicide, suicide attempts, and of course, suicide deaths. Now, in this large cohort of over 1,000 school-aged adolescents of the SAIL study, they found that 7% endorsed psychotic symptoms, and that this resulted in a 10-fold greater odds of engaging in suicidal behavior. And specifically, those with comorbid depression had 14 times greater odds of having a suicide plan or suicide acts compared to depressed, non-psychotic youth. And those with suicide ideation were 20 times more likely to endorse plans or acts if they also had psychotic symptoms. So overall, those with psychosis were 70 times more likely to have made a suicide attempt. Now, the SAIL study was based in the community. When we look at clinical samples following a first episode of psychosis, we also see an alarmingly high rate of suicide attempts and suicide deaths. In one longitudinal study, the suicide rate was estimated to be 11 times higher in those with early psychosis compared to the general population in the first year after initial contact. It was 7 times higher 5 years later, 4 times higher 10 years later, so the risk does appear to diminish over time, though it's still quite elevated compared to the general population. And we also know that this increased risk is relevant across the age span and is the case regardless of psychiatric diagnoses. So in this large-scale collaborative psychiatric epidemiology survey, which assessed adults, those with psychosis symptoms were more likely to report suicide ideation and attempts. But most also met criteria for depression, anxiety, or substance use disorders. So psychosis was certainly the strongest risk factor. And in another cohort study of first episode psychosis, we found that the highest suicide rates were among those with a depressive disorder with psychotic features and also in delusional disorder. So now some studies have found that positive symptoms of hallucinations and delusions are what accounts for the increased risk. And this is probably consistent with many of our clinical experiences in that hallucinations, particularly those that are self-deprecating or tell the individual, voices that tell the individual to kill themselves, are often a precipitating trigger for suicide behavior. And similarly, there are individuals with psychosis who engage in life-threatening self-harm behaviors who may be responding to delusion more so than having a specific intent to die. Now, there are numerous risk factors and warning signs for suicide, but rather than review them here, I'll refer you to the AFSP website, which really has a very comprehensive, well-organized list. But a key takeaway is that despite our improved awareness of risk factors and warning signs, that there is no typical suicide victim. People who attempt suicide or die by suicide are very heterogeneous. One study that illustrates this is a prospective study of 4,800 inpatients at a VA hospital, where they looked at a wide range of instruments and measures that included many of the known risk factors to see which were predictive of eventual suicide. And they found that all attempts to identify suicide deaths were unsuccessful, including the use of individual items, factor scores, and a series of discriminant functions. Every single attempt missed many cases of actual suicides and identified far too many false positive cases for it to be useful. Now, additionally, what makes it harder to predict or intervene is that suicide communications are often not made to professionals. Current best practice is that professionals should be asking directly, and that asking about suicide does not increase one's risk of engaging in suicide behavior, nor is it going to plant suicide ideation in that particular individual. What is no longer considered best practice is the no-harm contract. Clinicians should not rely on this as a form of intervention, nor will it provide any legal protection to clinician in the event of a suicide or subsequent lawsuits. You may be familiar with the use of no-harm contract as a means of therapeutic engagement. So, for example, you might have heard some clinicians say, well, I need you to be committed to this treatment, but you also have to be committed to being alive because that's the only way we can do treatment. And that's not exactly what I'm talking about. That's a little bit different. What I'm talking about is not allowing yourself to have a false sense of confidence if someone does indeed sign a no-harm contract. Now, suicide communications are often made to others, and this highlights the importance of the role of gatekeepers, family members, friends, teachers, physicians. Gatekeepers are especially important for clients who experience psychosis. Managing suicide in this population really involves an all-hands-on-deck approach. And here are some gatekeeper tools. QPR, which stands for Question, Persuade, and Refer, is like the mental health version of CPR, where the goal is to identify and stabilize a crisis and direct the person to appropriate care. It's intended to be used by gatekeepers who may not be mental health professionals. And I provided some links in the slides if you want additional information. Now, if you're a healthcare provider, it's recommended that you utilize a brief screen, suicide risk screen, such as some of the ones listed here. Some of these are now standard practice in emergency room departments or with PCPs and pediatricians. However, just two important points as you do these as an interview. It's important to not approach it like a checklist, to be empathic and genuine. And second, these screens have a very high false positive rate. So it is of the utmost importance to be very, very judicious before resorting to hospitalization. Someone reporting suicidal ideation does not mean that they need to be hospitalized. I've seen many teens and young adults lose trust in being able to talk about their suicide ideation because they've been hospitalized for doing so in the past. Okay, now another important tool for gatekeepers is means restriction. Many attempts are impulsive and usually there's some ambivalence involved. There was this New Yorker piece on survivors of a Golden Gate Bridge suicide attempt, and as you may know, the survival rate of jumping from the Golden Gate Bridge is very, very low. Yet those who survived were glad they did, and I really like this quote from this one survivor. I instantly realized that everything in my life that I thought was unfixable was totally fixable, except for having just jumped. There's also data to suggest that means restriction works. Firearms are the most common cause of suicide deaths, so we know that those states with the least restrictive gun laws have higher suicide rates. And sadly, in youth, these firearms usually belong to the parents. There was also an Oxford University study which found a 43% decline in suicide deaths by Tylenol overdose after Britain changed the required packaging laws to using blister packs. We have to remove each pill individually. Okay. So here's a graphic of suicide deaths by means. We strongly encourage families and other gatekeepers to be aware of what methods the at-risk individual is thinking of and to keep the environment safe. So for examples of how to do this are to remove or lock away all firearms, lock up sharps such as knives, over-the-counter medication, prescription medication, remove belts and cords, alcohol, toxic cleaning supplies. If a family feels too inconvenienced by locking up daily use items such as medications or cleaners, I would strongly suggest to not buy or have around the huge economy-sized bottles of these products, but just have small non-lethal amounts available if they don't want to lock them up. Now, moving on from gatekeepers, let's talk a little about the role of clinicians. So let's say someone's been identified as being at risk. What other information should we try to obtain? Here are just a few examples of some suicide risk assessments, which are much more comprehensive than the screens that I mentioned earlier. These are all interviews, and similar to the screens, it's important to not administer the interview as a checklist, but rather as a clinical interview with compassion and authenticity. Okay. Now, here's some of the common elements in each of these interviews. And of course, you don't have to use a standardized suicide risk assessment. You can get the same information by doing good, detailed clinical interview. The first point is that therapeutic alliance is key. If you're the individual's clinician, you may have already established this, but if you're a covering clinician, it's really important to take an empathic and collaborative stance. Because it may very well be tempting for the individual to deny their suicide ideation and get out of this interview, particularly if they're concerned about being hospitalized. But some of the questions you might want to ask is, about ideation. What exactly are they thinking? Are they thinking, do they have thoughts of, well, sometimes it'd be easier if I were dead, or thoughts of, I'm thinking about jumping from this bridge. How often do they think about suicide, and how long have they been feeling this way? Are the thoughts fleeting, or do they tend to stick around? And you want to ask about intent to die. So how strong is the urge? to kill yourself? Do you intend to act on your suicidal thoughts? And if it's not known, you want to know, well, when you felt this way in the past, what's happened? Have you acted on your ideation before? Do they have a specific plan? What is their plan? And have they been mentally rehearsing the plan? Also, do they have the means to carry out their plan? Do they have access to firearms? What about substances? Large quantities of medications? Do they live by themselves? And I also do like to ask about protective factors. What are some of the things that have kept you alive? What do you value? What's important to you? So now let's move on to talk a little bit about interventions. Now, these are some empirically supported interventions that were developed to specifically target suicidal behaviors. But unfortunately, at this point, none of them have been developed or tested with clients with psychosis. So it's likely that adaptations to these interventions will need to be made. For this webinar, I'm going to focus a little bit more specifically on safety planning intervention, as that's now considered standard best practice and can be utilized by a number of people caring for a client. So safety planning intervention is a standalone adjunctive intervention that can be implemented by an individual's primary therapist by integrating it into their ongoing therapy, or by someone who's not their therapist, such as a covering or supervising clinician, or by a healthcare worker in the emergency department. It's a one-session intervention that lasts about 25 to 45 minutes. It's been implemented in multiple settings with high-risk patients, and it's considered empirically supported treatment at this time. Okay. And here are the steps of safety planning intervention. And note that the creation of a safety plan is just really one part of the larger clinical encounter. It's a very important part, but there's some preceding steps and following steps following the safety plan. And I'll go through each of these steps in greater detail. So the first step is the risk assessment, which I had spoken about earlier, and hearing the individual story. It's really important for the individual to be heard and for this to be a collaborative process. And while you're getting to know their story, it's also important to pay attention to information that you might want to incorporate into their safety plan. After assessing risk and hearing their story, it's important to get their buy-in to want to do a safety plan. So it's often helpful to provide the rationale that suicidal thoughts come and go. And so the purpose of the safety plan is to have a detailed list of strategies to help you get through the times when the thoughts and feelings are most intense and prevent them from escalating. It's hard to think clearly when someone is having strong feelings and urges. So that thinking is done ahead of time. Now, the next step is to create a safety plan together. And you can easily access a template like this one online or make one yourself. There are also several safety planning apps available now. Now, there's 6 to 7 steps of the SPI, with the first 5 being hierarchical as they escalate in terms of the intensity of the intervention. But it's also okay to jump to any step depending on what the client needs in the moment of crisis. And at the end, I also like to add some questions about reasons for living. So I'm going to walk through this in greater detail. So step 1 is to identify the warning signs and triggers that precede a suicidal crisis for that particular client. And it's very important for this to be individualized and as specific as possible. It may also be helpful to present the rationale for identifying warning signs that it's easier to, that you need to first know when to take out your safety plan, refer to it, and use it. And it's also easier to implement the safety plan and also more likely to be effective if you can use it earlier in the process when you have the warning signs. So in developing this step, it's really important to try to get as specific as possible. So some examples, if the command hallucinations tends to be a warning sign, try to get specific. It could be this voice telling me to kill myself. Other types of warning signs, thoughts and images, for example, traumatic flashback, or an image of the client stabbing someone else. Certain emotions, be specific, sad, tearful, angry, down on myself. Behaviors, increased urge to smoke, poor sleep. What physical sensations might be warning signs? Increased agitation, a need to pace. And external cues or events can also be triggers for being near a certain location, or perhaps hearing a news story or something to that effect. Okay, now step 2 is internal coping strategies that one can do on their own. And this is important because people are often alone when they're thinking about suicide, and having coping strategies that they can use by themselves really enhances self-efficacy and helps to instill a sense of personal agency. And this is really important for people who struggle with chronic suicide ideation and may be at risk of burning out loved ones. So some examples of strategies might be going for a walk, listening to music, taking a shower, exercising, engaging in a hobby. The idea is to distract the mind. And once they've identified some strategies, it's important to evaluate how likely are they to use a strategy and how likely is it to be effective. Are any of these strategies potentially problematic? So for example, if someone's suicide plan is to jump in front of a car, or if that's their ideation, then taking a walk is not a good coping strategy for them. And music can be a great coping strategy, but it can go both ways depending on the song. So I often encourage some clients to make a safe playlist. It's also important to evaluate any obstacles to using these strategies and to prioritize the most feasible ones. Now, step 3 is our social contacts that can provide distraction and connection. And the goal is really to get people outside of themselves and connect with others, but not necessarily to talk about their current crisis or distress. So this can be particular individuals. Help the client identify people with whom they have a non-complicated relationship. It can be a cordial relationship. The goal is not to self-disclose the crisis, but to identify someone who can provide distraction. So an example of someone who might fall in this category is a younger sibling or a niece or nephew, someone that might look up to the individual to play games with them. So you might want to ask, who helps you feel good when you socialize them? Who helps you take your mind off your problems, at least for a little while? This can also be places. So where can you go when where you have the opportunity to be around people in a safe environment? And it's important to avoid places where substance use takes place. So for example, bars. Some better, healthier alternatives might be grabbing a book and getting coffee at a coffee shop or going to the gym. Step 4 is for contacting friends and family who can provide support during a crisis. And theoretically, these are different people than those listed in step 3. In this step, the client would solicit support, not just distraction from these individuals. And it's important to ask how likely they would be to reach out to these individuals. And can the safety plan be shared with these family members or friends? Now, sometimes it becomes challenging to identify people for this step. And if at all possible, you don't want to leave the step blank. You can always say, okay, well, this is something we can go back to and fill in later. Let's just proceed. And if they're struggling to identify family or friends that they can turn to, ask if there are any 12-step program sponsors, peer support, or peer navigators that they can turn to. Now, step 5 is soliciting professional support. And this is a good opportunity to educate clients about crisis lines. The people who work on these hotlines have lots of experience talking with people who have thoughts of suicide, and they're very good at talking people through these difficult moments. And they won't have a knee-jerk reaction of sending individuals directly to the emergency room. However, if they are concerned enough, they certainly will call an emergency intervention or 911 while also keeping the individual on the line. So step 6 is not necessarily the next sequential step after step 5, but it's something that's important to keep in mind as the client is navigating each of these steps. It includes some things that may have been done previously, such as means restriction and creating a safe environment at home. And it can also pertain to making sure that they're in a safe environment when they're in a crisis. It's important to know what are the things the client needs to be distanced from. And finally, I find it's particularly useful after we go through the steps of the safety plan to think about and write out reasons for living. What's kept you going so far? And maybe a particular family member or a loved one or a pet, or it could be for spiritual reasons or that they believe suicide is against their values. It may be because suicide will prevent them from doing certain things that they still want to do. No reason is insufficient. Now, after completing the safety plan, it's worth reviewing it with the client and thinking through the logistics of where to keep the plan and revising certainly as necessary. I often recommend taking a photo of it using their cell phone and asking whether they'd be comfortable sharing the plan with anyone. It's also worth reminding them that they don't need to do the steps sequentially. They can jump to the strategies that are most helpful in the moment. That if something in step 2 is not helping, that's okay. Go to step 4 if they feel like they're really in need. So I think of the safety plan as a living document. If you have the opportunity, it's occasionally good to go back and revisit it and see if it needs updating. And I'm going to be presenting some clinical vignettes, and I'll demonstrate in case in which it was necessary to go back and reevaluate the safety plan. So let me jump into some clinical vignettes. So the descriptions I'll be providing are individuals identified as having clinical high risk with features of psychosis and who have exhibited suicidal behaviors. The first is the patient I will refer to as A. A is a 26-year-old single white trans female. She's college educated and currently unemployed but living with her roommates and received some financial assistance from her parents. Now, A has no history of suicide attempts, but does have chronic high suicidal ideation with a specific plan, and this has resulted in 4 hospitalizations. A's psychosis symptoms are that she reports having multiple personalities and believing that she was possessed by demons, and she's also exhibited grandiosity. Now, most of her symptoms have remitted, though she still does report that multiple personalities still speak to her. She reports depression, anxiety, and a high degree of interpersonal sensitivity, and the diagnostic picture is still unclear. Now, with regard to the broader clinical context, A has done a number of chain analysis with her therapist to identify triggers and warning signs. But she's otherwise rejected aspects of DBT, such as doing a diary card and going to practicing skills. Now, through these chain analysis, they've identified that most of the precipitants of her suicide crisis are interpersonal in nature. That she very quickly goes to suicide as a means of solving her problems. And her specific plan involves going to a particular bridge and jumping. And what's really alarming is that she goes there weekly to contemplate suicide. And recently she faced a romantic rejection from someone that she frequently relied on during suicide crisis. And this is a bit of a pattern for her as she engages with other people through her suicidal ideation. So this is what a safety plan for A looks like. Now, the safety plan should be as specific as possible, but for the purposes of de-identification, I've left certain details to be unspecified. This is sort of to give you an example. But step one, in terms of what are the warning signs, it's noticing urges to walk to this bridge, thoughts and feelings of rejection, and she has a specific voice telling her to kill herself. So those are all warning signs. The internal coping strategy, she enjoys playing video, role-play games, and watching Netflix movies. With regard to step three, she can reach out to certain friends to play multiplayer games, including card games, acting games, role-play games. Step four, she does have a number of friends that she can call for help, and she can also speak with her mother. Step five, she's been given a number of suicide hotline numbers and has called in the past. She can call her therapist during certain hours, and she is someone who will go to the emergency department on her own. And step six is that she does live with roommates who help her keep her environment safe. And her important reason for living is that she really wants to help other people one day. So now, with regard to managing non-acute risk, the client keeps her safety plan on a phone, and she and the therapist periodically review and revise. And here's an example in which they had to do a recent revision because she has faced the recent romantic rejection from someone who was rather high up in her step four, and it was too much responsibility for this person, and the person needed a break, and so therefore, the clinician had to redo the safety plan to change the people that she would contact. She and her clinician have been generally using an acceptance and commitment therapy approach. They work on building her value of wanting to help others and her value of friendships, and the fact that suicide would conflict with those values. This patient is quite fused with the idea of suicide, and so they've also begun to gradually use diffusion techniques to label her suicidal thoughts and urges as these are her automatic problem-solving strategy that has mostly not been effective in that it has strained and compromised her friendships. And also as a way of diffusion, they're diversifying her activities and diversifying the ways in which she engages with other people. Okay. So moving on to another clinical case. This is B. B is a 24-year-old single white male with some college education, working part-time, has a significant other, and living at home with his parents. He has a history of one prior interrupted attempt and multiple incidents of cutting. He's been hospitalized twice due to increased suicide ideation. He's been diagnosed with bipolar disorder with psychotic features, and some of his psychosis symptoms include hallucinations of voices telling him to kill himself, thought insertion, paranoid thinking, and he occasionally has intrusive thoughts of himself harming other people. He also reports mood lability and anxiety, poor sleep, substance use, and when depressed has thoughts of how bad his life is and of his worthlessness. So with regard to the clinical context, B is working with his therapist using a DBT-informed model, and they have done chain analysis, which reveal that his self-deprecating thoughts, which are secondary to psychiatric symptoms, were the primary drivers of suicide ideation. And suicide ideation also led to substance use. And because substance use was always on the chain of suicide ideation, this was an early target of intervention. And through therapy, the client did manage to become sober with support from AA and NA. Now, B's plan was he had a non-specific plan of overdosing, but because we knew that this was a plan, the therapist ensured that the parents were also aware of this risk so that they could make the home environment as safe as possible, including the management of medication. So this is an example of a safety plan for B. Step 1, warning signs and triggers are his urges to use and the thoughts of my life sucks. And also poor inadequate sleep is also a trigger, and this is poor sleep or insufficient sleep has been identified as a rather strong risk factor of suicide. For his internal coping strategies, fortunately, he finds that intense cardio exercise is very helpful. So this is something that is very beneficial to him, but even taking a peaceful walk or breathing and mindfulness exercises does help calm him down. B does have some friends to reach out to, and these friends, they go rock climbing, they can work out. He has a number of supports, including his parents, a significant other, and AA and NA sponsors. And also on his safety plan is his therapist number, which he can call during certain hours, and also numbers for suicide hotline. And as I mentioned, the therapists have worked with the parents to help maintain a safe environment. And B's reasons for living are that he really values his independence and is very connected to his significant other. Now, B keeps his safety plan on his phone, and he and his therapist periodically review and revise. And they track his thoughts and urges on a DBT diary card, and they review it weekly. So unlike the prior clinical example, B really took to DBT and DBT approaches. So now, while B still has many mood and psychosis symptoms and the self-deprecating thoughts remain, but these, as well as the suicidal thoughts, are more manageable. And he's really responded well to skills-based intervention, particularly the skills in DBT's distress tolerance module and the emotion regulation module. So in therapy, they will practice and review these skills. And currently, they're working more towards building a life worth living. Okay, so moving on to the final clinical case, and then we can open up for questions. This is C. C is a 24-year-old African-American single male who obtained his GED but could not attend high school college due to psychiatric symptoms, specifically emergent psychosis. He is unemployed and living at home with his mother. He had a history of 4 prior attempts and over 5 hospitalizations for suicidal behaviors and disorganized behaviors. He's been diagnosed with paranoid schizophrenia. He has hallucinations of voices telling him to kill himself, thought insertion, thought blocking, delusions, cognitive disorganization. And he also reports depression, anxiety, and chronic daily suicide ideation without a plan. So this client was on a number of high-dose antipsychotic medications, but continued to experience psychotic symptoms daily. And he was also very mistrustful of therapists due to past experiences of hospitalization. In particular, one in which he told his therapist about the psychotic symptoms, and then he was hospitalized immediately afterwards. And after that, he avoided seeing a therapist for 5 years. And I came into contact with this client in the context of a research study. We had begun work using an ACT-informed model, which was also really resonated with this particular client. We used ACT videos and metaphors and really focused on acceptance of his symptoms and then identifying, clarifying his values and goals. So with regard to safety plan, the warning signs and triggers were his urges to stop medication, also increased agitation and when he would start pacing, speaking loudly, and voices telling him to kill himself. With regard to internal coping strategies, he found listening to music loudly on headphones to be helpful. Video games were a very good distraction, and taking a walk. Now, the complicating aspects of this clinical case was that he had very limited social support. So step 3 was a little bit challenging, but he found like gaming with others was something that he could do, to sort of be virtually with others. Step 4, it was also very difficult to find supportive others that he could talk to. Fortunately, he had a very close and supportive relationship with his mother. He was able to call his therapist at certain times, and we also provided him numbers with suicide hotlines. His mother helped with maintaining a safe environment. He stated that his reasons, mother, his dog, his goal of becoming a writer one day. And Steve kept his safety plan on his phone, and his mother had a copy that she put on the refrigerator in the kitchen. And he and the therapist would periodically review and revise. And as I had mentioned, the ACT approach really resonated with this patient, and continued work on accepting of these symptoms for what they are. So he continued to have many symptoms and self-deprecating thoughts during the course of therapy, but he found them to be less distressing, and there were no, other than ideation, there were no suicide behaviors. We worked on him staying on his medication. We worked on his mother getting more resources, and worked towards him enrolling in classes at a community college. So, I think that safety planning is a great tool if the risk is not imminent. But if the risk is imminent, then certainly, I would not hesitate to. It's a very complicated balance. You want to be judicious, because hospitalizing someone when they do not want to be hospitalized, one thing is that you do. It can potentially damage trust and reliance. However, sometimes it really is an intervention that's needed to keep that individual safe. And I've put up resources in terms of the crisis text lines and the suicide hotlines that I have on the safety plans. So please feel free to use those. And I've also want to finally acknowledge that there's a lot of great resources out there on the internet. So some of those that I rely on, including the AFSP has a great website, the Suicide Prevention Resource Center, and the Zero Suicide Initiative. And I just want to thank some colleagues that have contributed materials for this presentation. And we've got about 15 minutes for questions and a discussion. Vanessa, do you want to moderate? Okay. Here, I see some questions now. Let's see. So what do we do about folks who are really isolated and experiencing paranoia and distrust about engaging with others, about some of these suicide beliefs? I think that's a really, really good question. And I think that, I do think that the use of hotlines, which provides some distance, can be helpful, or crisis text lines. In this type of scenario, it probably is easier to rely a little bit more on the internal coping strategies. If you know that reaching out to others because they're distrustful or paranoid, if that's going to be a barrier, I would try to more robustly develop, okay, what are your warning signs? How do you know when you'll need to use some of these skills? Have as extensive of a list of coping strategies as possible. And perhaps, even if you can get them to do so in the session, maybe practice a call to a suicide hotline or a crisis text line if suicide ideation is something that they chronically struggle with, and then process how that went. What fears do they have about that? And then examine with them, were there any negative consequences of the calls that we made or the outreach that we did from last week? Okay, let me look at some other ones, and I'm just trying to catch some of these questions as I can. So for those of us that work at a university, are there any skills that we, the counseling center, can train faculty and staff in regards to intervening with students outside of making a referral to us and contacting public safety? So for those of you, and I think that, so this is what I mean by gatekeeper training, that it might be good to do some suicide awareness trainings for faculty or residential counselors, and incorporate QPR into those trainings, because I think that oftentimes you're right, especially for young people, they may not have the same self-advocacy skills as they would with as an adult would, and so I would really, in the College Counseling Center, I would really step up the gatekeeper effort. Okay. All right. Let's see. Some questions here. Aha. All right. All right. Would you have any information? Okay, we talked about college students. What do we do about clients who are extremely quiet and are not aware of themselves, and what is helpful for them? I don't know as a response a lot when trying to safety plan with activities and support. Oh yeah, this is hard. Right, so you might see this with someone who is very withdrawn or might have some negative symptoms. So I think that one possibility is, I think it will be very important, if you're trying to do a safety plan anyway, to be as proactive in that process as possible. So what I mean by that is learn something about how it is that they spend their time and bring the things that you've learned about them in their session onto the safety plan. And anticipate some I don't know, if, to questions of, how likely do you think you will use this? It might be a more proactive, giving them ideas of, well, I know you really like art. You appreciate art. Can we buy a particular sketchbook or one of those intense coloring books? Can we do this? Have a little safety kit for you that you can just go to. So I think it does take a lot of more proactive work on the part of the clinician, drawing in information that you know about them from all other parts of your work with them. Okay. Okay. Oh, do you think that providing Narcan for those that have previously made suicide attempts with drugs, opiates, would be impactful on preventing future suicides? To be perfectly honest, I don't know anything about that, but it sounds like that to have Narcan available sounds wise in that type of situation, but to be perfectly honest, it's not something I know very much about. Okay. I see another question here. Oh, what is QPR? QPR is a question. Oh, someone answered that question. Persuade and refer. Do you have any thoughts on safety planning with clients who have TBE and or cognitive impairment and struggle to recall the plan even with visual reminders, pictures on phones? So this is an example where I would get others involved, including other gatekeepers. I mean, I think in the clinical case C that I mentioned, he had a lot of cognitive disorganization, and there were times where because we were unsure whether he would be able to find it or find the picture on his phone, his mother put it in a very prominent place in the kitchen on the refrigerator. And so this might be a client where you might want to make multiple copies, physical copies, and put them in various places. Put one in the wallet. So I would probably problem solve that with his gatekeepers. Any suggestions for paranoid or delusional participants? So I think, of course, having those symptoms greatly complicates things. And, and again, I think that, and I think part of what makes, I see another participant is saying that, I'm often deferring a lot to gatekeepers, and I do really think that for this population, it is indeed the case that gatekeepers are very important. But what if they don't have gatekeepers? So again, for paranoid delusional participants, to the extent that you can get gatekeepers involved, that would be really, really instrumental. I think the other thing for paranoid and delusional participants, I would recommend when you write out the safety plan that they're writing it out in their handwriting. So that's a very minor intervention, but I think it's a very important one, and that they have multiple copies available. Without supportive others, this work becomes very, very difficult, obviously. And again, I think that part of the, I guess one of the things that I would think about in terms of the overall treatment and not just the crisis intervention would be that for that particular participant, expanding the social base will have to be a target of the intervention. Because that really, I think does also help mitigate suicide risk. So I think that, is something that one, would certainly want to prioritize working on during the non-acute phases. Okay, let's see. I think let me scroll up here. Let's see. I think I covered most of the questions. And I think it's a little hard for me to gauge, being just, having the microphone work in one direction. It's a little bit difficult to engage with you all. But if there's some part of what oh, okay, I'm getting some other questions here. I was going to say that if there's some part that is not clear, then feel free to engage in the interaction through the board here. What if a client does not verbalize suicide ideation? What are some signs to look out for? Okay, so some signs to look out for are changes in behavior. So I think that certainly getting more withdrawn, changes in cognitive or affective states. Other things are just more passive communications, and these could be sort of passive thoughts of, it'd be better if I just didn't wake up, or life is too hard. Obviously giving possessions away, communications that are atypical. So those are some of the signs that I would be looking for that would be concerning. We have just a couple more minutes left. Any other questions? Let's see. Oh, some of you are offering great suggestions like meetups, internet chat rooms, internet-based support groups. These are wonderful suggestions. And I do think that, a lot of, I think one of the common things that I've alluded to in one of my clinical case presentations, and also the comments that are being posed is, I think the greatest difficulty is when they are socially isolated. And that's why we really need to focus on different ways of engaging clients socially. And that might mean through meetup groups, internet, or playing video games online, some way of interacting with others to feel connected. Oh, podcasts. Interesting. So someone said another passive way to help clients feel connected is through podcasts. These are great ideas. Okay. Great. So, I've included a lot of links to my slide. I hope that is useful to me. And if anyone has any additional questions for me, you can also reach me by email. I can give that to you. It's syen1@bidmc.harvard.edu. And I hope that this has been helpful.
Thank you all so much for joining us for today's webinar, and you'll be receiving an evaluation form right afterwards, and we hope you enjoy the rest of your day.